and thank you, Dr. Green, for having me down here. I've known Rick for a long time. I met Rick when he was playing baseball at Duke, undergrad, back before he wore sleeves to class. He still at the gun show. Yeah, but it's really nice to be here. I mean, I see a lot of familiar faces. Alan just got me through the oral boards. This last month, I spent about 4 days at his course, and that's a tremendous service to practicing neurosurgeons who have to get in shape real quick. And Mike Wang, who I think is doing probably the most innovative technical work in spine advancement right now. So it's a wonderful pleasure to be here. When Rick called me, he wanted me to focus my talk on a more practical talk on how we've sort of, at least in my first 3.5 years of practice, and now what we're doing at CMSA, integrated a sort of a web-based tool, a registry platform into everyday practice. And you know, for a long time, when I first started in Baltimore as an intern, I really noticed that we generate data in everything we do delivering neurosurgical care, in the ORs, in the clinic, in the hospital. It's all around us. I mean, we're just dumping it on the floor, and at the end of the day, it gets swept sort of in the trash can. And I sort of equated that to my 2 years I spent in the lab at Duke. It's like running gels day in, day out, and at the end of the day, turning the lights off and just sort of throwing it away. And so the reality is that the solutions that we now look for in healthcare reform to get lean, to understand waste, comparative effectiveness, quality improvement, we generate that data every day. It's just a matter of reaching over, picking it up in a systematic, prospective, meaningful way, analyzing it in a valuable way, and feeding it back to get better. And so when I started my career almost 4 years ago in Nashville, I really wanted to, from the start, integrate throughout our comprehensive spine center a methodology, a way that we collected, we left nothing on the table. We collected everything that happened around the care we provided. So I wanted to give a little bit of a perspective on that experience, because I know there's some discussion here about ways to do that. These are my disclosures. Most of it's in health information technology and health economics. Really doesn't bias what I'm talking about today. As you know, healthcare costs in the U.S. are unsustainable. We're at nearly 18% of the GDP. Surgery is about 7% in total. It's unsustainable. We'll be in about 50 years over half of our nation's GDP. So this is happening. Stakeholders all around us outside of neurosurgery are looking at us and will be dictating change. So understanding value in what you do is huge. This is the paradigm shift that we're now beginning to realize. If you're in a high dollar service line like we all are, neurosurgery, spine surgery, we will be sort of the front lines with value-based reform. And having a stake and a say in value is incredibly important. Cost data is everywhere. Everyone has it. It's a part of the transaction of providing healthcare. There's bills, there's costs, there's payments, and that's all memorialized and readily available. The numerator in the value equation is not. And to avoid cost-based reform, which is the cheapest care is no care, and certainly if you provide top dollar, high cost therapy, there are dozens, if not hundreds of therapeutic alternatives that are much cheaper to you. So particularly in neurosurgery, we really have a huge stake in defining value in the numerator of quality, and that really is what is safe, effective, efficient. So what helps people, and this is where outcomes data is critical. We are the gateway to patients. We are who touch and treat and care and actually have access to this data. Insurance companies aren't, hospitals don't, payers, employers, policymakers. So it's really up to us to help frame the numerator in this debate, or else a lot of what we do could easily go away. This is an example, and I'll come back to this in a minute, about the relative worth of spine treatments from a cost-based perspective and value-based perspective. As you can see, medical treatment for lumbar disc herniations, one of the cheapest treatment modalities for a very common congenital lumbar spine disease, whereas you see a lumbar laminectomy infusion for same level recurrent lumbar stenosis. This is off of our registry data over 4 years at Vanderbilt that's integrated throughout both medical care and surgical care. But when you really start putting the quality of life gains in context with what the cost per a quality adjusted life year are. It drastically changes the bang for the buck. So miles per gallon are important. Every major stakeholder right now, from a policy standpoint, are introducing paradigms to reduce, disincentivize, or eliminate non-effective care. Again, effective is the end point here. Financially incentivize providers and hospitals to deliver care above quality benchmarks. So in the quality paradigm now, look, the policy shift is to only pay for therapies that are proven effective in the real world, and to incentivize or shift care to providers, centers who deliver that effective care above quality standards. There are some guidelines of how to do this. If you follow this, Institute of Medicine and the Federal Coordinating Council for CER, it's actually written in the healthcare bill. It's a central tenet to PCORI, which now is a $30 billion entity, is that the establishment of prospective registries to capture patient-centered data from real-world practice is essentially the marching orders to do this. And low back pain and cervical spine disorders is really in everyone's top 10 from a prevalence and cost standpoint. This is from our newspaper in Nashville 2 years ago. Medicare data will open to rate doctors picking a specialist for delicate medical procedures such as heart bypass, or we'll call it low back fusion. It's going to get a lot easier in the near future. It's a giant step forward in making our healthcare system more transparent, promoting increased competition, accountability, quality, and lowering costs. Doctors will be individually identifiable through Medicare files to the public, but personal data on patients will remain confidential. So, you've really got to hope that this free market, if you will, consumer reports driven by national Medicare data gets it right. And you can imagine, about 90% of the cases I did at Vanderbilt, traditional tertiary care center, were fusions. I was doing a lot of re-ops, a lot of high risk, a lot of deformity, a lot of tumors, and without risk adjustment, without any idea of what the benefit to my patients were. Looking at basic coding data and cost, I'm going to look pretty bad in the paper. So we have to sort of grab the bulls by the horn, and one way in which we've used our integrated registry solution has been just to do that, to make sure we protect our local stake and stance and place in our local environment in that very dynamic marketplace. I got to know the chief medical officer at BCBS in Tennessee fairly well through some collaborations, and this is something that jumped out at me, is all 38 BCBS member companies are under tremendous pressure and rushing to devise their value-based purchasing platform for spine care. They understand there's huge variability in the quality and cost of care, and they want to shift, they want to profile centers, hospitals, doctors to figure out who's a good buy. This is an example of that. BCBS in Tennessee signed a multi-million-dollar contract with a company called Triad Healthcare, and that's what they do. They do all the pre-certification. They record the indications, the diagnoses, what surgeries they approve, and they actually track your patients through their healthcare, as a payer, from the payer perspective, and actually will contact and interview those patients to get track longitudinally, an attempt to obtain the numerator, the benefit per cost, to try to understand whose patients aren't getting better in the state of Tennessee, so they can profile you and understand what is a good buy and what is not. Anytime there's a demand in a capitalistic society, there's a huge void that needs to be filled, and there are new VC-backed registry entities popping up everywhere, and the hospital systems are signing on with a multitude of these outcomes registries. And most of these companies pitch the ability to define value. So everyone wants to know how to trim the fat. Do we just not pay for B&P in our OR anymore? Do we just not pay for this widget from this 10th vendor for this spine case? They don't know how to do it, and they need help doing it. These companies are filling that space. So we decided to use something called RedCap, and RedCap's really, I'm going to sound a little bit like a software sales guy here, but it's really a tremendous platform for centers like Vanderbilt, Miami, CNSA, If you're a not-for-profit, if you're a provider group, you're a university system, this is something that you can use for free if you're a part of the REDCap consortium. And it is equal, if not superior, to pretty much any private registry software package you can have. You can go out and buy. It's the REDCap consortium is a group of almost 900 partners, medical centers. Miami is one of them, and now about 75 countries. And what it is, it's a web-based data entry system, super easy to use, and it allows you with secure data protection to enter in any customizable data fields in real time, and allows you to integrate that into your workflow. And you don't have to be a software guy. I don't know anything about programming, but this is incredibly user-friendly. It powers almost 100,000 projects right now, and it's incredibly robust. This is sort of the consortium partners worldwide. Miami, you are one of the REDCap consortium. So this is really a really nice tool. I just want to show some of the things about, some of the aspects about it. But bottom line is it's no cost. And you'll go out and spend your department $100,000 a year contracting with a private entity. The value here is tremendous. It's secure, it's web-based, it's been validated in, again, hundreds of practices. It's extremely quick. You can open up multi-site access to any group. So if you wanted to create a brain tumor consortium of Florida and you wanted to gather up 6 other brain tumor practice groups to be a part of it, you sit down and in a weekend you can just design a standardized platform with case report forms and give access to those 6 centers, and it really costs you nothing. It costs you a weekend. So it's really incredible. You can customize it in any way. You can export data any way. You can be on an airplane with Wi-Fi, in Nebraska, and export your data. This is how we powered the National Neurosurgery Registry, and it's fully customizable. You can upload videos, pictures, anything you want. And there's really 2 ways to do it. So if you wanted to start it, I'll walk you through it. You can either create offline a data dictionary in something even as simple as Excel and upload it into REDCap, and it can auto-populate. The way we did it was on an online sort of designer. And this is sort of what it looks like. No programming, no 1 zeros and fancy code. You're just clicking and dragging on bubbles. Say, I want to do the online designer. And then you say, I want to create case report forms. So I want to create a patient demographic form. I want to create a baseline interview form. So you tell it you have these. And you say, I want to ask the following question. I want it to be either a text box or a multiple choice or a calculation. Or you completely just click and drag on what you want. So here I say, I want to know the ASA grade for my spine patients. These are the answers that I want the user to be able to select. I don't want it to be identified as protected health information, or I do want this to be identified as PHI because I may want to export data that is de-identified. So up front you tell it what is a PHI. So if you share this data, or you have your postdoc share it, or you have a resident share it, you make sure regulatory-wise you're safe. When it just pops up like this, and this is a demo. So it says, look, this is your ASA grade, this is the bubble form, this could have been a drop-down box. It's just that easy. You tell it what you want it to do. So there's a variety of different things. You can just tell it to enter dates in this format. You can upload documents, images, videos up to 60 megabytes. So every case, if you want to get a baseline tremor or gait, whether it's Parkinson's or normal pressure hydrocephalus, whether you want to create a memorialized registry of deformity pre and post Scoli films, you name it, video, imaging, any data that you can enroll. So you can imagine what a robust research platform and consortium that you could create. You can have all of these different features, and you can create calculations. So you enter date of birth, it will automatically calculate age, different types of matrix fields. I don't want to belabor the point here, but BMI calculation with height and weight. So you can make this do whatever you want. There's branching logic. For example, if we're doing a spine registry and we're bringing together a Southeast consortium and we create a template for all 12 to use together and get everyone on the same page. Look, I mean, if it's an operative, this is branching logic. So, I'm only interested if it's a LAMI or fusion or non-fusion or an inner body was used or what the implants were, if it was a posterior approach. I don't want to ask those questions for everybody. So you tell it, look, if it's a posterior approach, boom, it knows in a smart sort of questionnaire to pop up these answers. If it's an anterior approach, it only asks questions that are relevant from an anterior approach standpoint. So you can create intelligent case report forms that are specific to the case. And then you can have longitudinal repeating, so I can create in the system, all right, well, we have certain case report forms at baseline. I want these to come up at 3 months and these to pop up at 12 months for longitudinal care. So if you want to institute quality of life, return to work, things for brain tumor consortium, for spine in particular, you can create certain forms to pop up in time. And this is really important, especially if you have a study coordinator. You create a scheduling, automated scheduling timer, so you don't have to keep up with who's due for what, and then it will auto-populate a calendar. So you can have someone in your office, you can have a study coordinator. They come in and they say, all right, it's Friday. I'm not trying to keep up with my 3,000 patients, my 200 patients. They just follow what the calendar says, and it might say at 9 a.m. I have to make this call, I have to do this interview. So it keeps everything. As you can see, and this is just an example of one of our study coordinators. They just walk in, log in the REDCap, and then it's automated. And they know which, it's a 3-month call, it's a pre-op call, it's a 12-month call. And so it really, really keeps it simple. So you don't have to go out and spend $120,000 on an FTE who has 20 years of experience in managing hundreds of patients. You could get a medical student to sit down, and they just have to plug and play off the schedule. So, and then exporting data. You can export data in really any way you want at any time. In a number of different software packages, and then you can assign user rights and so forth. So don't want to go through the details too much, but there's a tremendous amount of tools that you can really customize if you're like me, where you're just not a programmer, you're not into it, you don't happen to have a $200,000 in the bank to spend on this. There's secure messaging, so anybody that signs up and you want a part of this registry platform, whether it be your partners in your spine center, your brain tumor center, whether it be with colleagues across the world, you can do this, and you can have protected conversations, attach videos, imaging, so you could set up a platform for quality improvement, case report discussions, anything you wanted. So it's really a robust platform. So we decided that we were going to customize something like this, and we wanted to integrate it into our Vanderbilt Spine Center. And we're now doing this at CNSA, which is my new practice, and there's 24 of us, so we're a very, very large group. And so how do you integrate this into everyday care? Because the key was you want to collect everything you do. You want to collect the outcomes of the patients you treat, the safety, the complications, all of these things. But if you don't want to affect the workflow, because right now our nurses, our NPs, all of us are inundated with EMR regulatory paperwork. So we wanted to create something that ran in parallel with the clinical enterprise, that didn't get in the way, that we weren't tripping over. And so this is essentially a schematic of how we did it. We have a central registry office. We have 3 FTEs who sit in that office. One of the first weeks when I started at Vanderbilt, I went to our, we have a CEC meeting where our CEO of the hospital, CFO, medical directors sit. And I made a big pitch, and I said, look, we need $120,000 a year at the spine center, and we're going to be one of the first spine centers that will position ourselves in a value-based purchasing market, and we will, in 3 years, be able to demonstrate to any stakeholder or any person who touches our system, who buys care from our system, what they get for the dollar. And we'll be the only person in our market to do it. They went for it, and they committed to a 4-year deal where they give us about $100,000 a year. We hired 3 FTEs that sits in this neurosurgery office space. We designed REDCap, like we just said. We said these are the baseline 3-month and 12-month case report forms we want. This is the data we want. And then care happens. And anytime a surgery is scheduled, you can do this for brain tumors, Parkinson's, spine, whatever. I get in my Outlook calendar, it's scheduled, I know on this date I have this surgery. Well, it also gets pushed to the registry office. So every single spine surgery that's booked in the Vanderbilt healthcare system, as it goes to surgeons' Outlooks calendars, it goes to the registry office, and they immediately enter that patient into RedCap, and it auto-populates, and then care happens. There's a pre-op visit, the pre-op notes are generated, obviously surgery happens, operative reports happen, discharge summaries happen, they come back at 6 and 3 months, those documents happen, and 12-month follow-ups happen, sometimes they don't. And that creates a tremendous amount of data in those documents. Okay, that's one source. The other source is these validated patient-reported outcomes instruments. So we didn't try to integrate that into all of our surgeons' hands. So every single, at every single visit, we basically phone bomb patients. So we've got 3 folks who will call and essentially call, whether in the morning, in the evening, and administer all of these patient interviews. And so what happens is we are able to get about an 80% capture rate in 1 year. And we have our 3 FTEs will have a little earpiece. They've got 2 computer screens up. They've got the RedCap data entry module. They're just plug and playing. They've got the EMR open another screen. They got the patient on the line. So they're able prospectively, baseline 3-month, 12-month, to pull data from the EMR, the phone interview, and enter it in a standardized way. And they're not running around going to clinics. And they will bang out 30, 40, 50 patients a day. So in this way, we're able to do about 1,300 patients prospectively every year and do all case capture. So this is what we all agreed up front that we wanted. I mean, we obviously take all the baseline diagnoses, variables, patient variables, clinical comorbidities, but we want to understand occupational, what kind of job they are, what's their education level, what are all the confounders. We use VAS, back and leg and arm and neck scales, osseoestry disability, neck disability, SF12, EQ5D, which is a health state utility. We use a Zung depression and MSPQ anxiety scale. And so we collect a tremendous amount of data. And in 3 months, we want to understand what was the length of surgery, what was the blood loss, what was the post-acute care episode utilization, SNF, inpatient rehab, home, did they return to work, satisfaction, everything you can imagine in the safety and effectiveness of care realm. And then this is what happens. Eventually, once you get into it, then you can start understanding, you can create dashboards, and you'll understand, are we helping patients in our hands? And so here we can cut it down by procedure. You see each one of these is lumbar disc, lumbar lamina, lumbar fusion, lumbar corpectomy, ACDF, but you can slice this in any way you want, and you can start understanding how are my patients doing on aggregate. We know we're helping patients, pain, disability, quality of life. This is unique. There's very little data out there on getting patients back to work. So patients who are employed pre-op, who state pre-op, they want to get back to work for our procedures. This data, by the way, is worth a lot to employers, particularly self-insured employers. So this is some of the earliest data on what does return to work look like, should it look like, what does best look like. But we can cut this by doctor, by surgeon, by any way you want, education level, disease type, and it's a great practice-based learning tool. When we first started doing this, I used to pull all other surgeons in mind. And as I was an early guy, first, second, third year, I'd pull per diagnosis and I'd see where I was performing well and wouldn't. There was certain disease like pseudoarthrosis. Some of my outcomes actually were not as good as some of my senior partners. And I started changing how I decided to operate or refuse pseudoarthrosis. So it was really a humbling and powerful thing. We were getting crushed on patient satisfaction. Our hospital would call meetings with the spine center and say, look, dermatology and cosmetics are getting 99%, grade 5 satisfaction. You guys are at 75% in the low back clinic. And it was ridiculous to me that they expected, that's totally apples and oranges. But they were hammering us about that. And this really changed things. I mean, I don't know what it's like here, but satisfaction metrics is crazy for surgery. They were doing 5% sampling of our outpatient clinics as a judge of, how good we were with our patients. I mean, 80% of my patients I'd send out of my clinic without a surgical solution, and they're unhappy. I'm not operating on them. I didn't refill their narcotics. So we changed the table and said, let's look at satisfaction with patients we treat surgically, and let's do all case sampling, and it looks very, very different. So this is a little bit about, who has the data really owns the conversation. That problem went away. So this is where it gets exciting. You don't have to sit back and get $100,000 to start doing comparative effectiveness research. You don't have to take 2 years to figure out if MIS or open is providing a better outcome. You can almost do this in real time. If you prospectively are collecting these validated measures, you can sit back and say, well, let's look at MIS and open TLIF in our practice. Let's figure out if this is getting patients back to work earlier. It looks like it was. What about time to get off narcotics? Mike Wang would tell you similar findings here, is that you can slice this any which way you want, and it becomes an incredibly robust learning tool, particularly for research. And so this is just some examples of that. We do a representative sampling of medical care. Look, the reality is in real world care in our hands, if you start looking, these are very flat curves. So you look at people who have structural spine disease, who have failed medical treatment, who are ideal operative candidates undergoing medical treatments, they just don't get better. And this is also in the spine world, it is a changed paradigm, because when you look at an artificial research setting, it's very different. This is health state changes in our spine clinic. These are folks with grade 1 spondy, and you look at the dotted line continued medical treatment. These are people who have failed medical treatment, who for whatever reason are recommended surgery and don't take it, and they don't get much better. So surgery in these patients is a significantly greater benefit. This data, it seems simple, but is highly valuable in demonstrating the value of surgery. Here's an example of understanding level of depression pre-op and outcomes after surgery. These are Zung depression scales, minimum, moderate, severe. Return to work curves are highly dependent on level of preoperative depression. Here's a scattergram, increasing depression at pre-op baseline, longer term to return to work, satisfaction, patient-reported outcomes. So we're starting to use Zung to weed out and refine surgical indication. You can follow trends. We institutionally moved towards vancomycin powder for all posterior spine surgery. We didn't have to pay a lot of money to do a comparative effective research. We just delivered care. And about 2 years after doing this, we just put data export, spent 4 hours and did some analysis, and it's a paper. But the bottom line is that our surgical site infection almost went away when we institutionally standardized intraoperative vancomycin powder. You can imagine any protocol, whether it be a protocol in your surgical ICU, whether it be how you do checklists, any health services research change, how the brain tumor program standardizes care. Once you have the data infrastructure to measure what happens in everyday care, you just institute changes, treatment paradigm changes, and you almost at no additional cost measure whether that's effective or not. This is something that's relevant to, I know what Rick and the brain tumor guys are doing. You start understanding predictive modeling. You start understanding what at baseline are telling us through our experience, okay, who is really responding to certain treatments and who is not. So in spine, there's a number of things that are going to confound or influence whether they are getting better pain, disability, quality of life. And you can start modeling this. The brain tumor example is that you have a multitude of treatment options for a GBM, which are, by the way, probably 100, 200 different types of GBMs. This could be, this could be gene shipping. This could be tumor banking. The reality is that when you measure hundreds of thousands of patients undergoing a multitude of treatments, and you measure the vast variety and outcomes that you see there, you can then begin to develop very personalized predictive modeling for personalized expected outcome. You can then begin to match the right chemotherapy, the right radiation, the right surgical approach based on biomarkers. So one of the things that we want to start doing is once you start having 2,000, 3,000, 4,000 spine patients, or maybe it's in this case it's brain tumor treatments, you can develop solutions up front that can begin to tell you how you're going to respond for your unique situation. Here's just an example of some personalized decision support tools. 2 patients, grade 1 spondy, both with a baseline ODI. One recommended 1 level, 2 level fusion, different BMIs, education levels, comorbidities. The odds of a complication are vastly different. Quoting them, the sport trial data is not really relevant to other than a very small subset. What are the chances that they're going to return to work by 3 months? 2 patients with grade 1 spondy, baseline ODI 50, 30, a number of unique differences between these patients. You know, you practice spine surgery, you kind of get the sense that just because their MRI looks the same and their pain levels are the same, they're different people. Okay, return to work rates are 40 and 90% likely, and this is based on thousands of patients who've come before them in our hands. What about effectiveness of surgery? Same thing. So you could argue that patient 1, well, you know, the MRI looks a certain way, their pain looks the same way, but maybe this is a surgery that should be prevented. So these are sort of evidence-driven informed decision aids. So predictive modeling can be very important. And then you can start understanding value. Here's an example in our spine center, the direct 1-year healthcare cost for a 1-year episode of care. And you can see the average cost was about, you know, $9,000 for medical management for lumbar spondylolisthesis. Look like a great buy, you know, if you're an outside stakeholder. But when you actually put cost per one, what does a quality adjusted life year gain cost you, okay? It actually is a terrible buy. It's $146,000 is what you have to spend for medically treating that disease for them to have a full quality adjusted life year gain. So this is what I showed this slide before, that it's completely different when you look at value of care and cost of care. And this is sort of where we need to head. So this would empower us to make decisions locally, to give us a place at the table when it comes to investing and paying for services that we need in our hospital system. The academic substrate is unbelievable. Once you have several thousand prospectively enrolled patients of all different flavors and treatments and outcomes for your academic enterprise, it's really a never-ending resource. So for the last 3 years, we've averaged about 18 peer-reviewed manuscripts a year just in spine off of this registry by our students and fellows, a number of platform presentations, a number of grants. So if anything, it's a huge academic resource once you're 2 to 3 years into this. And then something that we started doing is how do we demonstrate the value of our care? This is an example of our outcomes report that we started at the Vanderbilt Spine Center. We would send it out and we'd say, look, this is the treatments we perform. You see most of these mailers that go out talks about maybe some length of surgery readmission, but we include all of these patient gains: back pain, leg pain, neck pain, arm pain, back-related disability, neck-related disability, general health status, quality of life, return to work. So we can actually show this to the public, to anybody who wants to understand what you get at the Vanderbilt Spine Center to play in a value-based marketing system. Vanderbilt had its own health plan. We went to them and said, look, right now 50% of your insured patients are getting spine surgery outside in the Middle Tennessee area. We want to do all of that, and we think that it should be a value-based play to shuffle your care to us, and this would probably bring us an additional 300 spine surgeries a year. And we negotiated that. Part of that is an annual report. So every insured patient who needs spine surgery, who's recommended surgery now comes to the spine center for a second opinion, and if we agree, we'll get surgery. And a part of that is that we provide the health plan an annual report of their beneficiaries. So we say, for example, in this year, this is the number of patients we treated, this is the type of treatments we provided to your beneficiaries and what you're paying for, this was our length of hospital stay, this is an actual report we send annually to the health plan, this was our complication rate for all care. This here is the benefits that your patients and beneficiaries receive by having care at our spine center. The dotted line is an MCID, minimum clinical important difference, a threshold that is meaningful to patients. Now, we don't have a national benchmark because no one else is doing this, but we did use that as a meaningful improvement. And so we provide this to the purchaser, the payer. This is your patients getting back to work. So we've used this. We were providing this to Blue Cross Blue Shield Tennessee. We're trying to get a value-based contract with them as well. And this was essentially our plan to target self-insured employers in the market and use this data. Now I'm at CNSA. We have a division of, we call it Value-Based Innovation and Quality Improvement. Myself, Tony Asher, run this. There's a fair amount of dollars behind this now. We're in the process of hiring a PhD, have another quality officers, 3 FTEs. We use REDCap to power this. It integrates with our EMR. And we do now are starting total spine enrollment, and we measure everything at 1 year again for total care. We have 8 physiatrists who are partners in our practice, who are physician 25 to 34 in the group, and so we are now doing this for medical and surgical treatment. But the outputs to this, obviously we just got granted our residency, so the academic output we mentioned will be very valuable, but local branding, value-based proposition, we want to get into destination medicine to go out and get high dollar neurosurgery and surgical care flown to us. There's plenty of precedent for that if you follow that. And then payer and employer direct contact. And we have Bank of America 2 miles from us, and we've already started negotiations there. But using this data to win the confidence of stakeholders is important. N2QOD, I'm not talking about it today, but it's completely powered by REDCap because it is such a cheap and easy tool. This is how outputs come here. Now we've got 50 sites. We have now risk-adjusted measures of safety and effectiveness of spine care. And look, we're really good at blood loss. This is O to E, risk-adjusted length of surgery. We're doing, about average when it comes to effectiveness of care. And now this is our practice group now in a private market that we're now putting together that can start determining what does spine care look like in our hands. Same type of approach to any stakeholder who wants to do it. And now because we are participating in N2QOD, we have national norms, so we can show that we fuse less than the national benchmark for these diagnoses, that are actually our length of stay and our discharge, post-acute care utilization is lower. And actually, this is our observed return to work rate over expected, risk-adjusted expected. So, this is a very new concept in national surgical or medical care at all, to be able to generate a nationally risk-adjusted expected return to work rate after spine surgery. So we're trying to stay ahead of the game. And the last example.
Can I interrupt you 1 second?
Yes, certainly.
So the N2QOD, just to be clear, that's an anonymous thing. So you see the national norm when you submit your data to that database in that portal. No one else sees that. You can see your own numbers comparison to the national norm generated by everyone else's submissions.
So this is for our eyes only. This graph came to us from the program AANS for our eyes only, and we can use it however we want.
And then there are costs to participate in N2QOD.
Yeah, the N2QOD costs $13,000 a year, and it requires 50% of an FTE, which is going to be about 25. So it's about $40K in total to be a part of the national network.
And that interacts with REDCap because that's where you're.
And REDCap is the data entry portal in it.
And then use that data and submit it to N2QOD.
That's right. So if like us, we do all care, all capture for everything in spine through REDCap. So it's really easy. So we can just push that data to AANS, the Central Coordinating Center.
And if you do it for spine and the vascular, like J McGirt wants to do, does he pay another extra fee for his vascular N2QOD?
Yeah. So the way the NeuroPoint Alliance and AANS has set this up is that for a contract you get 3 modules. The only 2 modules that are live right now are lumbar and cervical. But that's right, Mako is one of the design team for vascular. There's a tumor module that's gone through the tumor section. They're not in production yet, but the idea is that you would get three for that contract. And lastly is about, value-based innovation. This is our outpatient surgery center. We own an outpatient surgery center. We're 51% owners. And this is how this data is important. We're able to demonstrate that effectiveness of care, safetyness of care, return to work is identical doing lumbar disc or ACDF surgery in the outpatient center. The difference is it's $4,000 less per case. And this is important because we're in a certificate of need state, and as we start trying to shift payer policy, we're the only spine surgery center in our region, so this can help drive business to our facilities. And it's also smarter care. It's cheaper for equally effectiveness. So take home is, evolving value-based purchasing market allows for large shifts and preferential patient referrals. Integrated registries allow for proof of quality and value of your services, and it can give you an upper hand in this emerging market of value-based contracting, ACOs, clinically integrated networks. It provides an incredibly rich substrate for comparative effectiveness research and can power a robust research enterprise for residents and fellows. REDCap is the tool that we use locally and also in the national registry. It's essentially free for an institution like Miami, and it allows standardized outcomes data capture across as robust of a network that you want to set up. And its feasibility in neurosurgery practice now has been demonstrated in over 40 practices. So thanks a lot for your time. I can answer any questions.